Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine a surgical resident from the late 1890s, César Roux, just staring down a case of severe gastric outlet obstruction. He has no modern antibiotics, no linear staplers. He just has a needle, thread, and a radical idea to completely reroute the human plumbing system.
Which is pretty incredible to think about.
It really is. And today, well over a century later, to all the surgeons and doctors tuning in, that same fundamental rerouting isn't just a basic surgical technique. It is a master key reconstructive principle. And in some cases, it actually acts as a systemic metabolic switch. But real quick, before we begin, please note that this content is for reference only, and you must always follow local guidelines in your own clinical practice.
Yeah, which is absolutely essential to keep in mind because as we're going to discuss, the anatomical geometry and the physiological stakes in these cases are incredibly high. I mean, every abdomen presents a completely unique landscape.
Right. And navigating that landscape is our mission for this deep dive. We're looking way past the routine steps of Roux-en-Y reconstruction. We want to understand why this specific configuration is like the ultimate solver for the most complex anatomical and physiological disasters you can encounter in the operating room.
Yeah.
Okay, let's unpack this. Before we get into the bariatric or oncologic applications, we need to establish the pure physics here.
Right, the fluid dynamics of it.
Exactly. The physics and fluid dynamics of the Y architecture. You are taking a continuous intestinal tube and engineering a definitive separation of the alimentary stream from the biliopancreatic secretions.
What's fascinating here is the sheer physiological advantage this architectural change provides. We are fundamentally manipulating peristaltic pressure and chemical flow. By dividing the junum, creating that Roux limb, and bringing it up to your target organ, you're isolating the upper anastomosis. You then reconnect the biliopancreatic limb much further downstream.
So you're deliberately separating the clean food pathway from the highly caustic compartment of the biliary and pancreatic juices.
That's exact.
I used to think of this as just a standard plumbing bypass, like, building a dedicated overpass for food so it avoids the caustic local traffic of bile, and they only merge safely miles down the road.
That's a great analogy.
But when you really look at it, what does this all mean for the healing tissue?
Well, think about the chemical reality of bile and pancreatic enzymes. Together, they are designed to break down organic matter.
Right.
They are inherently destructive to unprotected mucosa, especially fresh, vulnerable surgical connections. If you just performed a primary loop anastomosis, you're constantly bathing that new connection in a pressurized, highly caustic bath.
Oh, wow. Yeah.
But by utilizing the Roux limb, you prevent that bile reflux entirely. The upper anastomosis heals under incredibly favorable, low-pressure, chemically neutral conditions.
Which brings up the actual physics of that Roux limb, because it's not just about creating the bypass, right? It's about the specific length of that limb. You can't just pull up 10 centimeters of jejunum and call it a day.
No, not at all. The physics of the Roux limb are dictated by the opposing forces of peristalsis versus capillary action and retrograde flow.
Okay.
To effectively prevent that caustic biliopancreatic fluid from refluxing back up into the stomach or the biliary tree, the Roux limb strictly needs to be between 40 and 60 centimeters long.
Really? That long?
Yeah. Anything shorter, and the retrograde flow can actually overcome the downward peristaltic clearing waves.
So you are essentially relying on gravity and the sheer distance of forward peristalsis to act as a functional physiological valve where an anatomical one no longer exists.
Precisely. You are engineering a safe environment by taking away both the chemical stress and the physical pressure. And when you realize that manipulating this internal architecture alters the physiological environment so drastically well, it opens the door to understanding its broader systemic effects.
Which is the perfect pivot. Because moving from structural containment to how this rerouting literally changes systemic chemistry is just mind-bending. Here's where it gets really interesting. The most universally recognized application of the Roux-en-Y configuration is in bariatric surgery for morbid obesity.
Right.
Now, structurally, you are creating a tiny gastric pouch and hooking it directly to the Roux limb. And for decades, the logic seemed purely mechanical.
Yeah, the initial assumption was almost entirely based on restriction and malabsorption. The thought process was simple. The pouch is small, so the patient physically cannot ingest as much volume.
Just a physical barrier.
Exactly. And because you are bypassing the remnant stomach, the entire duodenum and the proximal jejunum, you are reducing the surface area for calorie absorption. It was viewed as a structural barrier to overeating.
But if it were just a structural barrier, you would only see metabolic improvements parallel to the weight loss. Yet, surgeons started noticing that patients with severe type 2 diabetes were leaving the hospital with radically improved glycemic control, sometimes completely off insulin.
Which is incredible.
Right. Days after the procedure, long before they had lost any meaningful amount of weight.
If we connect this to the bigger picture, we have to fundamentally reevaluate the gut. It is not a passive digestive tube. It is the largest, most highly active endocrine organ in the human body.
Wow.
When you bypass the proximal gut using a Roux-en-Y configuration, you are throwing a massive neuroendocrine switch. You are rewiring the signals that dictate hunger, satiety, and pancreatic beta cell function.
And this brings us right to the competing mechanisms, specifically the hindgut hypothesis versus the foregut hypothesis. Because we aren't just blocking calories, we are altering how food interacts with the mucosal receptors.
Right. Let's break down the hindgut hypothesis, which is critical here. In a normal, unaltered anatomy, food is slowly digested and absorbed in the proximal gut. By the time chyme reaches the distal ileum, most of the nutrients have been extracted. But with a Roux-en-Y bypass, you are dropping relatively undigested, nutrient-dense chyme directly into the distal gut at a highly accelerated rate.
And that rapid transit just shocks the system. That undigested food violently hits the L cells concentrated in the distal ileum much faster and with much greater nutrient density than evolution ever intended.
Exactly. And those L cells respond to this overwhelming stimulus by dumping massive amounts of incretin hormones into the bloodstream, specifically, GLP-1 and PYY.
Okay.
This massive GLP-1 surge aggressively stimulates insulin secretion from the pancreas, completely independent of weight loss. Concurrently, the foregut hypothesis suggests that bypassing the duodenum might also stop the secretion of some unidentified anti-incretin factor that usually promotes insulin resistance.
So the Roux-en-Y gastric bypass isn't just a surgical restriction. It is an anatomical hack of the endocrine system.
I love that phrase. Yeah.
The Y configuration physically forces a rapid nutrient transit that chemically forces a remission of type 2 diabetes.
It is a profound paradigm shift. We are utilizing a mechanical routing technique to achieve a systemic metabolic cure. The architecture literally dictates the endocrinology.
But as elegant as that metabolic switch is in an elective bariatric setting, the Roux principle isn't just for weight loss and diabetes. I want to shift gears to how this configuration functions when things go catastrophically wrong.
Oh, absolutely.
Because if this technique is so successful at tricking the endocrine system and healing healthy tissue, what happens when we deploy it into a surgical disaster zone? We're talking about complex oncologic resections, hepatopancreatobiliary salvage, and just devastating revisional cases.
This is where the absolute durability of the Roux principle is really put to the test. Let's look at gastric reconstruction following a total or subtotal gastrectomy for gastric cancer.
Right.
You've resected the malignancy, and now you have a severed esophagus or a tiny gastric remnant. You must restore continuity.
And the immediate thought for someone outside the specialty might be, well, just pull up a loop of jejunum and attach it. A simple loop reconstruction is undeniably faster. So why go through the geometrical complexity of dividing the bowel, creating the Roux limb, and performing two separate anastomoses?
Because a simple loop in this context is often physiologically disastrous. We mentioned earlier that bile and pancreatic enzymes are highly caustic.
Right, the chemical burn aspect.
Exactly. If you perform a simple loop reconstruction, you are creating a direct, continuous channel for those biliopancreatic secretions to wash right past and reflux directly into the gastric remnant or the esophageal stump.
Which leads to severe alkaline reflux, gastritis, and esophagitis.
And we really need to emphasize the cellular damage there. We aren't just talking about the kind of heartburn a patient gets from normal acid reflux.
Right, it's way worse.
Oh, much worse. The esophageal squamous mucosa is absolutely defenseless against an alkaline mixture of bile salts and pancreatic protease. It causes deep, agonizing chemical burns, mucosal slouging, and intractable pain. It drastically destroys the patient's postoperative quality of life.
So the Roux-en-Y configuration is chosen specifically because it is a non-physiological yet highly protective route.
Precisely. It guarantees excellent downward drainage and virtually eliminates that devastating alkaline reflux.
So in the oncologic setting, you are accepting the higher technical demand of two anastomoses to prioritize the long-term functional survival of the mucosa. And that exact same logic translates beautifully over to HPV surgery.
It does. Consider a a hepatocoagulinostomy for a severe bile duct injury or a malignant biliary obstruction like a cholangiocarcinoma where you've had to resect the extrahepatic biliary tree,
Okay.
the normal pathway into the duodenum is gone. You have to drain the liver safely.
So you bring up that roux limb to the remaining hepatic ducts. And again, the Y configuration is doing double duty here. It provides that low-pressure drainage route we talked about, but it also physically distances the liver from the alimentary stream.
Which is paramount. You absolutely cannot have enteric contents, food particles, and gut flora swimming back up into the intrahepatic ducts.
Because that leads to ascending cholangitis, right?
Ascending cholangitis, liver abscesses, and sepsis. The divided 40 to 60 centimeter roux limb acts as an impenetrable functional barrier against ascending contamination.
It makes perfect sense for isolating clean systems. But let me push back on this a bit, especially when we talk about complex revisional surgery. Creating two anastomoses seems like a massive undertaking. Why go through all this trouble for a fistula or a duodenal stump problem? Isn't it overkill to rewire the whole system?
This raises an important question,
Yeah.
but it's the exact dilemma surgeons face when they open a catastrophic abdomen. It absolutely feels like a massive undertaking, but you have to realistically visualize the environment of a blown duodenal stump. We are talking about a frozen abdomen. You are dealing with dense, concrete-like adhesions, severe peritonitis, and tissue that is practically melting from uncontrolled enzymatic digestion.
So the tissue integrity is completely compromised.
Exactly. The duodenal tissue in that state will not hold a suture. If you attempt a primary repair or a patch on a devastated, inflamed duodenal stump, it will blow out again, 100% of the time.
Wow.
The tissue is ischemic and the intraluminal tension is too high. A Roux-en-Y is an overkill in this scenario. It is an incredibly elegant bailout.
Because you were bringing a completely virgin blood supply into the disaster zone.
Yes. The roux limb allows you to mobilize healthy, well-perfused jejunum from outside the zone of inflammation. You can bring it up to bypass the unsalvageable duodenum entirely.
That's brilliant.
It is. You restore continuity safely, divert the flow away from the leak, and allow the catastrophic area to heal passively. In many severe salvage situations, the roux configuration is literally the only geometrical option that won't result in a fatal postoperative leak.
You are bypassing the wreckage entirely, which really forces us to look at the practical reality of executing this. I mean, if this Y configuration is the ultimate reconstructive skeleton key, if it cures diabetes, prevents mucosal chemical burns, and salvages a hostile frozen abdomen, what is the actual surgeon's calculus?
Yeah.
Let's dive into the immense preoperative planning and the severe geometrical limitations of pulling this off.
For anyone visualizing their own OR decision-making, the most critical concept is that Roux-en-Y is never just a rote, step-by-step operation. It requires a vivid, three-dimensional awareness of the patient's unique mesenteric vascular geometry.
Because you aren't just stretching a tube, you're mobilizing a blood supply.
Oh.
And the vascular geometry of the mesentery is incredibly unforgiving.
Unforgiving is the right word. To get that roux limb to reach up to the liver or the high stomach without tension, you have to divide the mesentery deeply. But in doing so, you are actively sacrificing the primary arcades feeding that segment of bowel.
Oh, I see.
You become entirely reliant on the marginal artery to supply the distal tip of your roux limb.
Which means if you miscalculate your division, or if the patient's marginal arcades are incomplete or atherosclerotic, you induce immediate limb ischemia.
And an ischemic limb means a catastrophic anastomotic leak. Surgeons have to meticulously transluminate the mesentery, identify the vascular windows, and sometimes even clamp the vessels temporarily to ensure the marginal supply is robust before making the definitive cut. It is high-stakes anatomical chess.
And even if you nail the vascular supply and get a tension-free, perfectly pink anastomosis, you are fundamentally altering the layout of the abdomen. You are creating new pathways, but you're also creating new potential spaces.
That is the major long-term trade-off. By dividing the mesentery and bringing the roux limb up, you inherently create mesenteric defects, specifically Peterson space, which is the defect between the mesentery of the roux limb and the transverse mesocolon.
Which is a massive risk factor for internal hernias.
It's a significant risk, particularly in the bariatric population. When a patient loses a massive amount of visceral fat rapidly following a gastric bypass, those mesenteric defects physically widen.
Making it easier for things to get trapped.
Exactly. The bowel can easily slip into Peterson's space, twist on its axis, and cause a closed-loop obstruction and strangulation. Surgeons have to meticulously close every single mesenteric defect with non-absorbable sutures to mitigate this risk, and even then, the risk is never zero.
Add to that the baseline reality we discussed earlier. You are performing two anastomoses. Every time you divide and reconnect bowel, you introduce the statistical risk of a leak, bleeding, or a long-term stricture. You are doubling that baseline operative risk compared to a single connection.
Which brings us back to the surgeon's ultimate calculus. The physiological and functional payoffs must definitively outweigh the geometric risks.
Right.
You are trading anatomical simplicity for physiological superiority. You accept the risk of internal hernias and the technical demand of vascular mobilization because the Y configuration guarantees the controlled, safe mixing of food and secretions. It guarantees tension-free healing in a way no other reconstruction can.
It's a masterstroke of functional engineering. You accept the disruption of the plumbing to protect the long-term integrity of the whole system.
It really makes you wonder, though, about the broader implications of what we've explored today.
What do you mean?
Well, we've seen how rerouting the gut via a mechanical Roux bypass alters hormones so profoundly that it can trigger the remission of type 2 diabetes. This raises an incredible question for the future of medicine. What other entirely mechanical surgical techniques might secretly hold the key to curing systemic metabolic or autoimmune diseases?
That is a staggering thought. Could the future of endocrinology actually lie in the hands of reconstructive surgeons? It completely blurs the line between anatomy and biochemistry, form dictating function on a systemic level. Well, if you liked this content, then do not forget to share with at least one of your colleagues or friends and spread the word.
Yeah, sharing these deep dives really helps us bring more specialized, high-level analysis to the community.
Absolutely. Also, check out our YouTube and other social media pages, and do check our previous season and episodes with some very relevant topics to keep the learning going. We have covered a lot of advanced physiological concepts that tie perfectly into today's discussion. Thank you so much to all the surgeons and doctors for joining us on this deep dive into the Roux-en-Y principle. Keep pushing the boundaries of what's possible in the OR, and we will see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.